kind of a mix. Take it away, Nikki.
Yeah. Hi, everyone. I know morale can get a little bit low this time of academic half day, but I don't think that this will last the full 37 minutes. And I'm hopeful you guys will learn a little bit, especially if any of the third years have just signed up for ABIM. I realize I do have to take this test, in fact. So I'm going to be talking a little bit about breast health and breast concerns using some MKSAP questions to guide us. So let's get started. To get started, like Caitlin said, I am not a breast expert and I have no financial disclosures about the breasts, but I have learned quite a bit as a member of the Women's Health Pathway. So in terms of my hopes for you all for this talk is that you'll, by the end of the talk, be able to describe the basic epidemiology of breast cancer. You'll apply your current breast knowledge to board review questions, and you'll be able to evaluate some basic breast concerns, including new breast pain, breast density, and a new breast mass. So why should you care about the breasts? Breast complaints are very common in the primary care setting, with more than 70% of women having breast pain or mastalgia at some point in their lives, and breast cancer happening in about 1 in 8 women, or about 13% in their lives. Also, all of your patients have breast tissue, regardless of their gender identity, and the primary care doctor is often the first spot that those concerns or issues are discussed. I also just want to highlight that breast cancer is the most common cancer diagnosed in women. Breast cancer is also an equity issue, so you are probably not surprised to hear that there are inequities in breast cancer survival, unfortunately. This actually was very shocking to me, or maybe I should not be as shocked as I am, but there's lots of different ways that there are inequities, especially in communities of color, in breast cancer survival. For example, Black women are 12% are diagnosed with metastatic disease 12% of the time at diagnosis versus 8 to 10% in other ethnic groups, and are more likely to be diagnosed at a younger age, despite having similar rates of mammography screening. Furthermore, there's a 39% increased mortality in Black women compared to white women, even controlling for disease severity. Specifically within the UW system, there are also huge inequities in mammography access and utilization across clinical sites and racial identities. So this is not just a national problem, but something that we're seeing here in the Seattle area as well. So let's get started. The first question is about evaluating a breast mass. Would anyone want to participate and read the question for us?
I will. Oh, Ruth, you want to do it? Nope, you already muted yourself. Okay, I'm on the spot, Nikki. A 44-year-old woman is evaluated for breast lump she noticed a week ago. There's no nipple discharge. She birthed 2 children, the first at age 25, and her menstrual cycles are regular. She has no family members with breast or ovarian cancer. She has no other medical problems and takes no medications. On physical exam, vitals are normal, BMI is 28. Examination of the breast reveals dense tissue bilaterally and no skin changes. A mass is noted in the upper inner area of the right breast, measuring 1.8 centimeters. It is firm, mobile, and non-tender with ill-defined margins. There is no evidence of axillary, cervical, or supraclavicular lymphadenopathy. The remainder of the exam is unremarkable. Which of the following is the most appropriate diagnostic test to perform next? Do you want me to read the options?
Or we can, our options are a breast MRI, a core needle biopsy, diagnostic mammogram, diagnostic ultrasound, or a diagnostic mammogram and ultrasound. Which answer is best? Oh, it's showing up on my screen. So the majority of you guessed E, which is diagnostic mammogram and ultrasound, with the next most common being a diagnostic mammogram. So the majority of you are correct that the correct answer is diagnostic mammogram and ultrasound. And the key part of this question is that the patient is 44 years old. So we evaluate breast masses depending on age, meaning that if a patient presents younger than age 30 with a breast mass, you proceed with an ultrasound of the affected breast. And if the patient is over 30, you evaluate it with an ultrasound and a diagnostic mammogram. So because this is pretty important, your evaluation of a breast mass depends on your patient age. So if they're less than 30, the initial evaluation is with an ultrasound. And if they're over, you order the ultrasound and the mammogram. And that's because younger women are more likely to have a breast mass be benign, like a simple cyst that can be aspirated under ultrasound guidance. Also, younger women have denser breasts, which we'll talk a little bit more about later this talk, meaning that mammography is less sensitive towards identifying breast masses. I also want to highlight that it's very important to order your mammogram as a diagnostic test, not a screening test. And that in that patient group over age 30, if you're ordering the ultrasound and the mammogram, the radiologist helps protocolize and decide which one to do first. And if they get enough information with one test, they often don't proceed to the other, but it gives the radiologist flexibility to choose the appropriate testing based off your order. Because I didn't know the difference, I did want to talk briefly about the difference between screening and diagnostic mammograms. So screening mammograms are obviously a screening test in patients that don't have current symptoms and are covered by insurance as part of preventative care. Generally, those mammograms are just collected via two angles, craniocaudal or up and down, and then mediolateral or side to side. You can compare that to a diagnostic mammogram, which is targeting a specific concern or complaint. And I learned that these diagnostic images are actually directly supervised by a radiologist who chooses additional angles and images to target the clinical area of concern. This is one of the reasons that if you're ordering a diagnostic mammogram within the UW system, generally you almost always send them to Fred Hutch. Although I think there are opportunities at Northwest now because these diagnostic images are actively being supervised by a radiologist. So our take home for question number 1 is that evaluation of a breast mass depends on patient age. Any questions about breast masses? If not, we can move on to question number 2.
Nikki, you may or may not know the answer to this, but if a man has a mass that's like in the upper chest, like breast area, do you know what the evaluation for that would include? Is that also age-based or is that different?
Yeah, that's a really good question. I actually was going to talk a little bit about gynecomastia, which there's a couple of differentiating features for in that situation. One is like, is the breast tissue bilateral and directly subareolar, in which case that's considered kind of gynecomastia, can be caused by medical conditions, medications, things like that. But kind of a more focal, indiscrete mass, not behind the areola, is more concerning for kind of a primary breast cancer. And generally the first starting point for that is an ultrasound. But if I had a patient come in even with kind of unilateral gynecomastia or concerning symptoms, I would probably proceed with an ultrasound to start. Good question. Okay, question number 2. I can make this a little bit bigger. Does anyone want to read question number 2?
I can read it. A 29-year-old woman requests advice after receipt of a direct-to-consumer genetic test result that included BRCA gene analysis. She has no breast symptoms and has not undergone any previous breast cancer screening. Her mother was diagnosed with breast cancer at age 48 years and ovarian cancer at age 60 years. She died at age 62 years. The patient's sister was recently diagnosed with breast cancer at age 41 years and is still living. The genetic test report is negative for BRCA1, BRCA2 variants. The family members have not undergone genetic testing. On physical examination, vital signs, breast examination, and other findings are normal. Which of the following is the most appropriate management?
Clinical BRCA genetic test, genetic counseling, MRI of the breast, or reassurance and no further testing? Thank you to all of my friends for participating in my talk so far. Okay, so the majority of you have picked answer B, which is genetic counseling, with some other interest for a clinic BRCA test and a little bit for reassurance and no further testing. So the correct answer is genetic counseling. This is a really growing field about genetic counseling, and access is constantly increasing, as well as indications. It's really important to remember that someone's entire family cancer history is relevant to their breast cancer risk, but also their risk for other types of cancers. And I really encourage you to ask patients during a wellness visit about their family cancer history and document it accordingly, as it plays a role in their eligibility for genetic testing. The language I like to use in a visit is, do you have any family history of cancer of any type? And sometimes you'll get into the nitty gritty with, oh, they had a basal cell carcinoma when they were, 85. But this brings up a lot of other types of cancer, pancreatic cancer, prostate cancer, things like that. We care most about those first and second degree relatives that are blood related. We're lucky that we do have guidelines over who is eligible for genetic testing provided by NCCN, or the National Comprehensive Cancer Network. This is the organization that also provides guidelines on cancer diagnosis and treatment options, but they also have an excellent document about hereditary cancer testing criteria. These documents can be pretty dense, so I tried to pull out kind of the pertinent information, but they're accessible for free if you create an NCCN account. So based on one's personal or family history of cancer, they can be eligible for genetic testing. So this table is overwhelming, but I'm going to try to break it down a little bit for you. And it's specifically talking about the clinical indications for genetic testing for high penetrance breast cancer susceptibility genes. This is BRCA1 and 2, but also includes 20 plus other gene mutations that have been associated with increased risk of breast cancer. So the one take home I want you to take away from this table is that more patients than you think are probably eligible for genetic testing. So that top section is talking about who to genetically test if they have a personal history of breast cancer. But I want to draw your attention to this lower section of people who only have a family history of cancer. So this is people with an affected first or second degree relative meeting the criteria above should be offered testing, meaning anyone with a first or second degree relative with a history of breast cancer before age 30, triple negative breast cancer, multiple primary breast cancers, male breast cancer, or Ashkenazi Jewish inheritance should be offered genetic testing. Additionally, on the right-hand side, you can see that anyone with a first-degree relative of ovarian, pancreatic, or metastatic or high-risk prostate cancer are also eligible for genetic testing. Last, anyone with more than 2 close blood relatives with breast and/or prostate cancer are also eligible. So this is actually a lot more people than we necessarily give it credit for. Generally, anyone meeting these criteria is eligible to meet with a genetic counselor. And we're going to talk a little bit more about what genetic counseling entails. So genetic testing and genetic counseling is kind of a black box. I feel like we don't get a ton of training about this, but the roles of genetic counselors are generally to collect a very detailed family history and provide a lot of education and support to patients and their families about genetic inheritance and the purpose of tests. They also provide counseling regarding the interpretation and implications of genetic testing and the limitations of testing and alternatives, like foregoing testing completely. There's also guidelines that I'm not going to get into around who should actually undergo the genetic testing itself. So I have many patients who have like their mother had breast cancer, and generally the genetic counselors do prefer for the affected individual to be genetic tested first. So if you have a patient with a relative with cancer, to encourage that patient to ask their relative to get genetic testing, which then informs their own personal risk. There is also, with the rise of increased genetic testing, a huge number of ethical considerations to consider as patients are having increased access to genetic testing. The first one is just the pure psychosocial consequences of genetic testing. Even if someone tests negative, there are impacts on the patient and the family. Sometimes there can be sense of relief or survivor's guilt if testing negative. People can be alienated by family who do not have the same risk status as well. There's also interesting ethics around duty to disclose to family members depending on genetic testing results. Currently, patients are not legally required to disclose to family members their own genetic testing results, but this can put providers in a challenging situation where it's a duty to protect patient privacy versus the duty to prevent harm in other patients. This could be especially challenging in a primary care setting where you're caring for multiple family members. Next, I want to talk briefly about racial disparities in genetic testing. There are kind of the normal disparities like implicit or explicit bias, access to healthcare, and lack of trust in healthcare systems. But there's also bias in the gene panels itself, meaning that gene panel testing are more likely to include variants seen in white people. And then last, there's issues with discrimination around genetic testing. There are a few laws protecting patients based off their genetic information, like the Americans with Disabilities Act protects against discrimination if you have a genetic disorder. And then the Genetic Information Non-Discrimination Act is legal protection against using genetic information by insurance plans or employers. This is not perfect, though. It does not affect other insurance markets like life or disability insurance, and then does not apply to certain employers, including employers with less than 15 employees, and then also some federal employers, including the Veterans Administration, the military, and Indian Health Services. I also briefly want to talk about direct-to-consumer genetic testing, which is going to become increasingly popular. This is not just the testing that talks about, what's your ancestry, but is actually testing for pathologic variants that can inform health risk. It's important to remember that direct-to-consumer tests are not diagnostic tests and have variable FDA regulation. They can test for things like BRCA1 and BRCA2, but are not comprehensive and don't test for all possible pathogenic variants. Last, it's important to remember that if you have a patient that tests positive in one of these at-home tests, it's very important to submit another sample to a clinical lab for confirmation. This is an example of one of these direct-to-consumer tests called colored genomics. It's a hard balance, when I talk about my own thoughts about it. I think it's increasingly accessibility to genetic testing, but to remember that no test is a perfect test can be challenging. So the take home for the genetic testing question is that many patients with a family history of cancer qualify for genetic testing, and you should refer to the NCCN guidelines to see if your individual patient qualifies. Any questions about genetic testing? Would you recommend sending that test ourselves or sending patients to genetic counseling if patients come with direct-to-consumer results they want to discuss? I probably would start with a referral to genetic testing just because they know more about kind of what gene panels to send and what particular variants are included in those specific gene panels. I think I would feel like I wouldn't even know where to search on Epic to do that. That being said, wait times for genetic counseling are long too. And so I think that there's a balance there. Yeah, exactly. And so then also if someone tests, positive for a CHEK2 mutation of a variant of unknown significance, which is something that sometimes these results come back with, the genetic counselors are able to counsel kind of more accurately and more comprehensively about how to interpret that particular test result. Being connected to genetic counseling also helps keep people kind of in the genetic testing loop, where people with pathologic variants or non-pathologic variants can be retested every 5 years or so. as we get more information about what genes are affected or could be affecting someone's individual health. Are there e-consults for genetics? That's a really good question. I don't think that there are, or at least I have never submitted a genetics e-consult. That could be an interesting resource. All good questions. Okay. We're doing okay on time. Next, we're going to talk about breast density. Would anyone want to read the breast density question?
I can read it.
Go ahead, Leah.
All right, so a 50-year-old woman is seen following screening digital mammography. She is asymptomatic and has no medical problems. Other than her age and sex, she has no additional risk factors for breast cancer and no family history of breast cancer. The mammogram report notes no suspicious lesions, but indicates that the breasts are heterogeneously dense, density category C. On previous physical examination, vital signs and breast examination were normal. In addition to education on breast density, which of the following is the most appropriate adjunctive breast cancer screening?
Breast MRI, digital breast tomosynthesis, repeat mammography in 6 months, or no further testing. So the most popular answer was answer A, breast MRI, followed by D, no further testing. And I'm excited that there is a little bit of disagreement about this because I learned so much about breast density to the point where I think I maybe included a little too much detail, but hopefully you guys will learn a little bit about breast density too. The correct answer is actually no further testing right now. So what is breast density? Breast density is calculated as the ratio of dense breast tissue, the gland, the ducts, and the supportive tissue, to the fatty tissue, and it's reported by the radiologist on the mammogram report. There are 4 categories of density, A through D, A being almost entirely fatty, B being the standard or scattered areas of fibroglandular tissue, C being heterogeneously dense, and D being extremely dense. And dense breasts generally refer to categories C and D. There are lots of factors that influence breast density, including age, where younger women have denser breasts, genetics, the stage of your menstrual cycle, use of estrogen-containing products, and body habitus. Why does this come up? Well, it's actually mandated by the state of Washington in 2019 to share breast density results with patients. It's called the letter, and patients may bring it up. It reads as this: your mammogram indicates you have dense breast tissue. Roughly half of women have dense breast tissue, which can make it more difficult to evaluate the mammogram. And of course, the line that says, please talk with your healthcare provider about this and other breast cancer risk factors. Together, you can decide what screening options are right for you. So people are going to get this letter and may have questions for you, the primary care doctor, about what to do. Like the letter says, dense breasts are super common. Up to 50% of women have dense breasts, which does decline over age. So the density declines the greatest during the transition to menopause, but many older women who are at increased risk of breast cancer still have dense breasts, up to 44% of women in their 60s and 36% of women in their 70s. But dense breasts are shown to decrease sensitivity of mammogram screening, as cancer is also dense on mammogram. And then dense breasts are also an independent risk factor for breast cancer as cancer develops in the glandular tissue. This is a graph that demonstrates that decreased sensitivity depending on breast density. So you can see on the left-hand side here that as density goes up, the sensitivity of digital mammogram decreases down to about 75%. You may ask yourself, this is the point of the question, do these patients benefit from additional screening? And currently it's kind of a hot topic of study. There is some early data that suggests there could be a small benefit in patients with extremely dense breasts over age 50, but data is continuing to emerge. And currently, widespread use of MRI for supplemental breast cancer screening in women just with dense breasts is limited by high cost, lack of availability, and potential reactions with the contrast medium. Furthermore, breast density does not seem to impact breast cancer mortality. So this is a graph from a study looking at the relationship between mammogram density and breast cancer death from 2012. So it was a little bit in the past, but it studied over 9,000 women, 1,800 of which died, and there were 900 breast cancer deaths in that cohort. This is, there's lots of images in this paper, but this is all comers, all stages of breast cancer. And it's a hazard ratio, meaning you're comparing it to kind of a baseline comparator, in which case this is scattered fibroglandular density, which is category B. You can see here that heterogeneously and extremely dense breasts, the hazard ratio crosses 1, meaning that is not an increased risk of death related to breast cancer, but the almost entirely fat cohort actually does seem to be at slightly increased risk, which there's a number of factors that could be contributing to this. So this brings up the question, how do I assess my individual patient's risk with or without their breast density? And I encourage you to use a risk calculator in a dedicated appointment to determine your individual patient's breast cancer risk. There's lots of risk calculators, but a good all-comer risk calculator is the Breast Cancer Surveillance Consortium, or the BCSC risk calculator, which is the calculator that takes into account breast density. You can see here, this is a screenshot of the calculator. It asks questions about history of breast cancer, age, first-degree relatives, prior breast biopsies, and breast density. It also brings up women's race or ethnicity, and I did not have a chance to look into how that actually changes the calculations for breast cancer risk, but that could be an interesting project at some point if someone has not studied that. However, there are other risk calculators that you may hear used. One of them is the Gale model, which is less commonly used clinically as there's limited inputs, but it's the calculator used for risk reduction medications like tamoxifen, so it's still used clinically in that setting. We talked about the BCSC model, which is probably a good, easy place to start in primary care, especially if you only have one relative with cancer. But the most commonly used one that we use in breast clinic is the Tyrer-Cuzick model, or IBIS, which has the most number of inputs and is best for an extensive family history. It's good if you have a family history of a young age at diagnosis, second-degree relatives with cancers, male breast cancer, or ovarian cancer. So it just takes into account more details. And just a reminder that these calculators should not be used for patients with a known genetic mutation, a personal history of breast cancer, or a history of high dose to chest radiation, which kind of put you in a separate risk category. Oh, sorry, I haven't been moderating oh, Leah, yeah, dedicated appointment. This is really hard, but this can easily take 30 minutes. So I definitely would encourage you to try to schedule a specific appointment for this. So depending on your risk calculator, patients are stratified into 3 different groups: high risk, intermediate risk, or low risk, depending on their calculated lifetime risk. There's also data around kind of 5-year risk, but if there's one take home, I want you to think about a patient's lifetime risk. If someone's high risk, this is the group that we recommend an annual mammogram alternating with an annual MRI starting 10 years before the age of diagnosis of the youngest affected family member, but not before age 30. So this, say the patient in the question prompt, we calculated her risk, and it turned out that between her breast density and a family history, she was high risk. In that case, a supplemental MRI would be indicated, but her breast density alone does not qualify for her for annual MRI. In the low risk group, that's kind of the routine screening group, less than a 15% lifetime risk, and that's that every year to every other year mammogram. The intermediate risk category is the hardest category for me, and probably where a lot of your patients end up falling. That's the 15 to 20% lifetime risk. And that the guidelines are shared decision-making, but there's not evidence for annual MRI or ultrasound screening. This is a group where you could consider starting an annual mammogram at age 40. Oh, sorry, let me go back to that slide. Just to remind you, this applies for all patients undergoing breast cancer screening, not just ones with dense breasts. So anyone coming in to discuss breast cancer screening, you could consider using one of these calculators to assess their individual risk. So the take home for this question is that patients with dense breasts on mammogram are at increased risk of breast cancer, but do not require additional breast cancer screening just based off their breast density alone. Whew. It's a lot of information about breast density. We have a few more minutes, so we're going to try to get through our final topic, which is about breast pain. Would anyone read the final question for me?
33-year-old woman is evaluated for a 10-month history of bilateral diffuse breast pain. The pain is severe in intensity, occurring about a week before her menstrual cycle and resolving afterward. She has generally lumpy breasts without a dominant mass and no nipple discharge. Her menstrual cycles are regular. She drinks a cup of coffee in the morning and another at noon. Medical history is otherwise unremarkable. She has no family history of breast cancer. On physical exam, vital signs are normal. BMI is 29. Examination of the breast shows dense nodularity in the upper outer quadrant of both breasts and no skin changes. Tenderness is elicited on examination of the upper outer quadrants of the breasts. There is no evidence of cervical, supraclavicular, or axillary lymphadenopathy. Which of the following is the most appropriate next step in management?
We have
Advise avoidance of caffeine. Advise use of a well-fitting bra, breast ultrasound, diagnostic mammogram, or prescribe danazol.
if anyone, Luke and I both had this question on our like ITE MKSAP. So, and I think we both got it wrong. Now we'll learn for the future. You guys are smarter than me. The majority of you chose advise use of a well-fitting bra with the next most popular answer being avoid caffeine. And the correct answer is advise use of a well-fitting bra. To take a step back, there's 3 different types of breast pain, and it's important to characterize your patient's breast pain in order to best determine evaluation and treatment options. So cyclic breast pain is the discomfort caused by normal hormonal changes associated with ovulation. Estrogen, progesterone, and prolactin all can stimulate ductal elements or stromal elements and contribute to cyclic breast pain. Non-cyclic breast pain, on the other hand, is not correlated to your menses and can be unilateral, bilateral, intermittent, constant, focal, diffuse, literally anything. Causes can include pendulous breasts, diet and lifestyle factors, cysts, mastitis, trauma, or cancer. And then the third category of breast pain is extramammary breast pain, which includes musculoskeletal factors like your pec major, costochondritis, paraspinal muscle spasms, and also nerve pain, as the breasts are innervated by the intercostal nerves, T3 through T5. So impingement or irritation of these nerves anywhere along their course can lead to pain felt in the breast or the nipple. So this is back to our question. And since we're running low on time, I'll kind of run us through this quickly. First, this breast pain is cyclic, meaning it occurs a week before her menses and resolves after. And then anytime someone comes in with breast pain, it's important to evaluate for suspicious features. And in this case, she does not have any suspicious features. As the pain is in both breasts, she doesn't have skin changes and no lymphadenopathy. So what features would make us more concerned about breast pain? And I kind of alluded to this, but things like nipple discharge, skin changes, a palpable breast mass, and lymphadenopathy all should move you toward diagnostic imaging. So again, depending on patient's age, that's an ultrasound plus minus a diagnostic mammogram. Also, diffuse versus focal pain is a big difference. So diffuse pain is more likely that hormonal change, physical support helps. And focal pain, you should consider a lump equivalent and proceed with diagnostic imaging. with our favorite, the ultrasound plus minus mammogram. And first-line treatment of breast pain is supportive. You can reassure people it's not cancer. You can recommend physical support with a well-fitting bra, warm or cool compresses, and pain management with Tylenol and NSAIDs as appropriate. Also, good news for many of us is that there's no evidence that decreasing your caffeine intake actually helps mastalgia. I wanted to take a minute too to talk briefly about medications for severe breast pain. They're second line because use is really limited by side effects. So one option is tamoxifen, which is that SERM. And then another option that was mentioned in the question is something called danazol, which I've never used clinically, but it's FDA approved that suppresses FSH and LH to treat mastalgia. However, suppressing FSH and LH can cause amenorrhea, hirsutism, and changes in lipid profile. So because of those androgenic side effects, it's really only recommended for persistent severe cyclic breast pain. So take home number 4 is that in a patient presenting with breast pain, evaluate for suspicious features. And if they're not present, you can just treat supportively, literally. Breasts in review. Evaluate breast complaints with diagnostic imaging depending on patient age. Many patients qualify for formal genetic testing, and you should ask about familial cancer history during your wellness visit. Breast density increases your breast cancer risk, but does not recurrently require different screening and isolation. And you can use a risk calculator to assess your individual patient's cancer risk based off personal and familial risk factors. Before we wrap up, I just want to say a couple of different gratitudes. Addie McClintock is the Women's Health Pathway Director, and I adapted much of the breast density content from a presentation by her. Nina Tan is currently staffing our breast clinic, and 80% of my breast knowledge came from 1 month of working with Nina. Addie Bardoff and Megan Williams did an excellent MKSAP women's health topic last year that I adapted some of these questions from. And Sarah Rieger, our co-resident, I used some of her content about evaluating a breast mass. I also appreciate the access to free MKSAP questions online that made this presentation possible. I'm happy to answer any questions in our last 30 seconds, but I appreciate your guys' attention and participation.